Uh, Good afternoon, everybody. Yeah. Great to see a full hall, especially on the eve of Dasara. And it's honor and pleasure to welcome all of the doctors, neurophysicians, consultants, and surgeons, and ICU staff, ER staff, the nurses, and the ER emergency technicians, radiologists, and all the stakeholders of not only our KIMS Begumpet Hospital, also from Gachibowli, Kondapur, and our Begumpet KIMS branch, who have come here to see this momentous occasion on which we are launching this AI technology. And not only this, from online also, all of about 21 centers are also connected live along with us, which shows the interest and the zest among all the consultants and the stakeholders of KIMS Hospital for interest in treatment, interest in knowledge. With this, I would like to say a few words about our what is this AI. Now, as I was looking into this, okay, we'll have a PPT.
Yes, I have it.
Yeah, first of all, we all keep on, we have heard about artificial intelligence, especially among our engineering colleges, and it's almost day in and day out in the TVs. When I was looking, what is artificial intelligence? It is it is an intelligence. Here, the human mind is not needed. The computer itself deduces and possibly gives solution to our problems also. I never thought that this would come into the healthcare now, but as we see, and the day has arrived when this rapid AI is now in our hospital. This is not a new technology. In fact, it has been there about 10 years, and it has proven to be a very reliable, very fast, and very accurate technology, which helps in early diagnosis and adequate diagnosis and adequate not only treatment suggestion, but also gives a very good prognostication how will a patient behave once the treatment for stroke is given. For example, I'll just take a small, I'll show the gist what a radiologist and for example, right, when we see that image, I'll try to say in simple languages so that we all understand. The image on the left side, the pink part shows that the part of the brain which is damaged, where there's a clot has occurred. Till now, what we used to see in the routine MRIs, that we used to see that part is gone, and we are giving treatment so that we are able to save the other part of the brain. Now, this rapid AI technology, what it has done, it also shows the part which can be saved. That is the green part. Therefore, now we are pretty sure it also gives a calculation, and that's the software that gives a calculation, that gives a ratio, that how much of the brain is involved and how much of the brain we can save. And that has been proved in many trials that it's very accurate, very specific, and also sensitive for the work it is doing. And it is our good fortune that we have this technology in our institute, and we can offer the same to all our sister concerns. And the same talk was going on whether we can expand it to other KIMS hospital, for example, the patient, if he is in Nagpur or if he is in Nellore, can we offer the same technology for such patients also? Possibly, Why? Because what happens is that we all know stroke is total time bound. After 4.5 hours till the recent time, in ischemic stroke, we couldn't do anything. This improves the window to 24 hours. Therefore, if the patient is far away also, if he is eligible, we can shift off and we can give the appropriate treatment and save a life. As we know, stroke is devastating, and any life saved due to that morbidity and mortality, it will bring lot of happiness to the not to the patient, even to the family. And that is the technology we have. And to take it further, I will invite Kaul sir to come and talk about it.
Thank you, Praveen. Stroke means brain stroke, which means suddenly there is a damage to one part of the brain, which causes paralysis or loss of speech. It is the most devastating condition which comes very, very suddenly when you are not ready for it. You might be in a meeting, you might be playing, you might be talking, and suddenly you are fell down. That's why it's called stroke, which means it strikes you suddenly. And you are least prepared. The family is least prepared for. You don't expect that it is going to come. And there are two types of stroke. One is a stroke because of the block of the vessel, and the block is caused because of a clot which forms there. That's called ischemic stroke. 80% of the strokes are because of that. And 20% are because the blood vessel ruptures. That's called brain hemorrhage. Now, one of the latest developments in the last, not latest, in the last 10-15 years is that you can remove that clot. But that clot has to be removed within 4.5 hours. After that, you cannot dissolve. You dissolve that clot. And that is dissolved by giving one injection, which is given by the vein. That's called thrombolytic agent. That was the technology so far. But in the last 4 or 5 years, now we are able to mechanically remove that clot out. And that is removed by interventional radiologists like Dr. Anantram. And the research from 2018 has shown that you can remove it even up to 24 hours. So that is one major development. But it cannot be removed in every person. That patient selection is very important, because it has been seen that there are some patients in which there's a total damage of the brain within few hours. Then there's no point to remove the clot because it's already gone. The building is already burnt. But there are some patients in whom the brain is surviving even up to 24 hours, and it's worth removing the clot. So that is the challenge, to identify those patients where there is a dysfunctional but not dead brain. Dysfunctional but not dead. And that is, in technical language, we call it penumbra. And in the last 2018, in the year 2018, 2 major studies, research studies came. One was called DAWN and one was called DIFFUSE. And they showed that significant number of stroke patients, even after 4.5 hours, you can identify patients where there is still brain which can be saved. The whole of it is not damaged. And in them you can mechanically remove the clot. And the software which those had used was this software, which is called rapid software. So after the advent of those studies, this rapid software became very popular all over the country. What it tells is simply, which Praveen has told you, that this much of brain is dead, but there is this much of brain which still you can, which can salvage by removing the clot. There are some patients where it will show the whole of it is damaged. So in those you will not do anything, you will give some other treatment. But in those patients where there is still a functioning brain which is not dead, you will definitely do a mechanically remove the clot. And there are ratios for that. They say that if the ratio is more than 1.8, it's worth taking it out. And as you have seen in this particular patient, the ratio was 4.4, 5.6, 8 point them. In them, you can confidently go and assure the attendants that if we do this procedure, you have got a good chance of. And the good thing about this is that stroke is not dealt by everybody. There are stroke teams in every hospital. There are residents involved, consultants involved, interventionists involved. And this information they will get on their mobile phone also. So suppose I'm walking on the road, on the mobile phone, I can immediately, and I can see this data and I can decide. Or somebody is traveling in a car or somebody is at the airport. They can immediately get the information and do this. So it is a really big revolution in our technology, because of which many more patients can be helped by mechanical removal of the clot. And now lately we are also thinking of, not thinking, already it has come in guidelines that even that intravenous injection also can be extended up to 9 hours. Previously it was only 4.5 hours. But if this technology shows that there is a salvageable tissue, then up to 9 hours you can, even without doing mechanical, you can do the intravenous technology. So there's a big promise in this technology which has been proven all over the world, and there are many centers in India which are doing it. So I thank Dr. Bhaskar Rao for making it possible for us. I'm sure it's a very good addition to our armamentarium for dealing with acute stroke patients. I think I will request Dr. Anantaram, who will show you radiologically, on these pictures, the salvageable part and the damaged part already, because he's the one who will be dealing with it.
Good afternoon, everyone. So from imaging point of view, like what the earlier speakers were trying to tell is, previously it was more or less a time window. We have to deal within a specific frame of a time window. Now the concept has changed to tissue window. So each patient will not progress to the very large infarct at the same rate. Some we call it as a slow progressors, some they call it fast progressors. So somebody can have a large infarct within less than 3 hours. Somebody can be having a large salvageable tissue up to 24 hours. So what is the ideal candidate we should be selecting? That is one thing. And what will be the best imaging modality to do this selection? Because what we realized is a successful recanalization is not equal to a very good functional outcome. So we have to pick up the candidates where there is a very good functional outcome when we do this procedure. So two things what we always are interested is, what is always the dead tissue, what is the salvageable tissue. So that is the ischemic core versus a penumbra. So, as Dr. Praveen has already shown that slide, I would just, for the sake of the audience, whatever we get two sets of images. One is the routine diffusion, what we are doing all these days for the stroke protocol. That is one thing. Apart from that, we do a perfusion maps. That is what we inject a contrast and then we take additional perfusion map. So if we see the right side, what we were getting were the pink colored coded, that is the infarct core we were getting. Now, indirectly, whatever we were doing all these days was an indirect assessment, but now a direct, both quantitative assessment is there and also by color coding. By a simple color coding mismatch also, you can be able to tell that whether this candidate is eligible for a mechanical thrombectomy or not. So the ideal scenario will be a small pink area with a large green area. So that is just by color coding. Apart from that, there will be a quantification values which are there, and additionally, what we get from the artificial intelligence is whether this candidate is eligible for a mechanical thrombectomy or not. So it is something like a detailed report which comes where there is both color coding and also quantification and telling that whether you can take it up this patient for an endovascular procedure or not. So that is where the most of the imaging comes into play, and rest of the points what previously also told is the processing to again coming back to the console, everything will happen in less than 5 minutes. So 5 minutes is usually the turnaround time, and within 5 minutes that all the results are sent to the core group where there'll be a radiologist, neurologist, emergency physicians, everybody, they get there an app where they can see both in PACS or any other system, whatever we want, even their laptops. So that is how we make the decision, and then we can intervene in a ideal candidate for mechanical thrombectomy.
Now I request Manas sir to come and say a few words.
Good evening. I'd like to know how many are doctors and how many are non-doctors. Can you raise hands? How many are non-doctors? No, not doctors, non-doctors. Yeah, so means I'll ask one of you what you have understood. We had already Dr. Anantram explained, Dr. Praveen explained, Dr. Kaul explained. I'll start with Rajendra. Well, can you give mic to him?
With the help of this software, we will come to know that further extent we can save the how much brain is damaged to the patient. If it is 4.5 hours, one kind of procedure we used to do now, and it can be extended further by doing this. We can save the brain or not. We will come to know how much is brain is functional and how much is damaged.
How much is damaged?
Yes.
So in a routine scan like this, no, means you have to calculate the volume of the brain damage.
Yes.
So if you're just given a scan like that, how will you calculate volume? Anybody can use their physics? Anyone can answer. I'm not. Do you remember your physics? You can tell. This scan is.
You can see that color coding, if it is, you can say it's a pink color one, it is around 10% is damaged.
Yeah, that is your guessing. I'm telling you how many mLs is damaged. Volume I'm asking. 1 liter, 500 ml, 300 ml. How do you calculate? Anybody from biomedical engineering? The engineers can tell better. Anybody is there from engineering? IT department? Yeah, if I give a glass of water, how will you calculate the volume?
Length and width.
Length, breadth, and width.
Yes, yes.
So as a radiologist, he has to get up in the night and then calculate in each slice, no, length, breadth, and the height. It'll take so much time, so long to give one report that this is the volume is affected, and then you give it to Dr. Kaul that 50 ml is affected, then he will decide whether thrombectomy to be done or not. So AI does it in few seconds. So that is what is AI, is to make life comfortable for Anantram and his team. So they don't have to get up in the night. It automatically tells that, okay, 100 ml is affected, and then now everybody has to start doing some work or not. So things are, AI has made life, it's not comfortable. It has made our life difficult because you cannot sleep in night because the reports will come fast and then you have to act fast. So don't think that we can sleep more. We have to work more now. It has not come only in neurology, that only stroke. It also is coming in surgery because the surgery also depends on the volume of the blood clot. If the blood clot volume is more than 20 to 30 ml, then it needs an emergency surgery. And if in the night you have to again calculate on each the length, breadth, and the height, and then make a calculation by 2, A, B, C by 2, and then tell that the surgery, it takes time. And so here it gives automatically along with the report infarct and volume of infarct, so you act faster. So that is how life will change and life become faster, and the only person who gets benefited is the patient, and all of us have to work harder. Thank you.
Always a unique perspective, sir. Now I request Bhaskar Rao, sir, to please come.
Good afternoon. All the units, I think, very happy, even though Praveen said before Dasara, everybody is coming here, so much of interest that you are showing. I was thinking we will be my successor. Now I realized that Manas has proved that he can be. So that is one. The most important thing, we are proud, the KIMS. This is the first one in AP and Telangana. This rapid AI is installing in our KIMS hospital groups. And we have nearly 13, 14 in the Indian context, but in AP and Telangana, this is the first one. The most important thing, all of you should be able to see what he was talking about, doctors, non-doctors. The purpose is anybody who is having a stroke, and I don't know how many of you know, 2-3 years back I had a TIA and a stroke, and all my neurology department saved me. I am here. And anybody who is having this little bit of stroke, paralysis or aphasia and all, the most important thing, previously they were only treating at around 4 hours. If they come to the hospital, then we can able to treat and they become a normal person. Now even up to 24 hours also, please all of you should be able to remember any of our friends, relatives, anywhere if you come across in the society, if there is having a stroke, please ask them to send it to KIMS, because we can able to identify within 24 hours and still we can able to salvage and lead a good quality of life after this tool of rapid AI. And we were talking about now we need about a special injectors to get that. And we were talking about whether the diagnostic centers also can able to do. It needs to be linked with us. So we are going to link all our 12 hospitals so that all the patients we can able to, you don't need to send all the patients here. And if they can able to send the images, our people will able to give and see whether we can still thrombolize or thrombectomy or whatever mechanism, so that we can able to provide a good quality of life for all our patients. That is the best we can do. The other diseases are different. Any person who is suffering with paralysis for a lifelong is a different ball game all the time. So that way, to help all those things, I congratulate the entire neurology department of KIMS group and the radiology and the neurosurgery and the IT team, where they can able to bring it and utilize it maximum. And this message has to send to each and every one of you, all our family members, all our friends, so that most of the patients do get a good quality of life. That is the purpose of meeting all those things here. Again, congratulations for the department and thank you very much for this opportunity.
I know many of you would be having some simple questions, doubts. Therefore, what we had thought is that we will have a roundtable discussion in which all of us can ask questions and clarify our doubts, so that, as Sir pointed out, this message will be important not for only the hospital but for the society as a whole. I request Kaul Sir, Anantaram Sir, Manas Sir and Bhaskar Rao Sir also. Please come to this. Yeah, sir, coming. Yes. To start with, to set the ball rolling, I will ask a simple question. So first to call Sir. Sir, do you really think this AI, now hardly we are doing 2 thrombolysis to 4 thrombolysis per month. Yesterday night we did it. Do you think this AI will help in providing the emergency thrombolysis to many more patients?
See, Praveen, there are 2 things in stroke. One is thrombolysis, which is done chemically by injecting intravenous, and second is thrombectomy. Can I go ahead?
Yeah, please, sir. Sorry.
Yeah. There are 2 things. One is thrombolysis, which is done by just giving intravenous chemical, which we call thrombolytic agent. And second is thrombectomy, which Anantaram is doing by pulling out the clot. First of all, in thrombolysis, I think it has extended the window. We can do now intravenous thrombolysis up to 9 hours. So therefore, it is definitely many more patients are going to come under this. And already in Apollo Delhi and in some centers, they are already doing, and it's already in the European guidelines that you can go. So that is a huge big advantage, from 4.5 hours to 9 hours. But that cannot be done by simple CT or MRI. For that, AI is. That is one. And definitely in mechanical thrombectomy, I think we are having many more patients once we show this salvageability. So to answer your question, will it increase the numbers whom will intervene? Definitely yes.
Why there was interruption, because now we have an expert of AI, Dr. Pradyumna Oak, who is online, and he has an experience for using the AI since last 5 years, and he's a interventional radiologist from Mumbai, and we are thankful to sir for being with us. Good afternoon, sir. Am I audible?
Good afternoon, everyone, and it's my honor and privilege to be in this panel discussion. We have been using AI for quite some time now, and it's an excellent tool for stroke treatment. As sir rightly said, Kaul sir just mentioned, see, the important thing is that thrombectomy results depend on selection of right patient. So we really need to do cherry picking, because in our setup, patients need guarantee. And there is a lot of literature coming now that we can, even large core infarcts, we can do thrombectomies, but we have seen poor results. And if you look at the large core results, it is 20%. So out of 10 patients, 8 patients, we are going to give bad results, which is very difficult to explain to the relatives in our setup. So AI, this rapid AI is an excellent tool where we exactly know what is the core and how much penumbra we have. And prognostication becomes very simple. And this mechanical thrombectomy is relatively safe procedure. Complication rate is low. So if we have a good core, small core, and a big penumbra, we really can cherry pick these patients, and we have an excellent prognosis. So it's not always clinical radiological mismatch, but we get a good radiological evidence of a good mismatch, which really helps in selecting these patients for thrombectomy, and it's really good tool. So we are very happy with Rapid AI, and it shows excellent results.
Yeah, thank you for that. As you have a good experience with that, sir, I'll ask the same question, sir. Before the AI and now, has the thrombolysis and the thrombectomy rates increased at your setup, sir?
Yeah, absolutely.
Yeah.
Absolutely, it has increased.
And one more, sir, the last point, as Kaul sir was pointing out in our internal discussions also. Now we are there is a suggestion of increasing the time window to 9 hours. Sir, is AI doing the materialistically and helping us to increase that time window?
Yeah, absolutely, because the Dawn and Diffuse trial, which were done up to 24 hours, so with the use of, and both these trials utilize Rapid AI software to select those patients of small core with good penumbra. So up to 24 hours, we can do this mechanical thrombectomy now based on
attention please.
Perfusion mismatch.
Code violet is activated at OPD1 pharmacy.
Sorry, sir. Sorry.
So with Rapid AI, definitely we can choose patients much later in the window, and sometimes we can even choose patients even beyond the window based on a small core and a big penumbra with big NIHs or high NIHs.
No. Thank you, sir. Kaul sir, any question?
Dr. Oak, nice to see you. Thanks for coming. Just one question was about this extension of IV thrombolytic window up to 9 hours. Based on this technology, because European Society has endorsed that, and I know in some centers they are doing it. If they show the mismatch ratio more than 1.2, what is your experience? Have you started doing IV window or no?
So not really. We go beyond, up to 9 hours only if flare is completely negative. But I'm not really aware of this new data where Rapid AI can be used.
The guideline is, let me clarify that, I again seen it, that in those patients where there is no occlusion, and you cannot do mechanical thrombectomy, and yet you show a lot of mismatch, then you can give them. And it's actually a strong recommendation they have given. Yeah.
Okay, I am really not aware of IV thrombolysis recommendation.
Thank you.
Yeah.
Thank you. I'll go through. Thank you.
Thank you, sir. Thank you for the valuable feedback. Real time. The next part I would like to ask Anantram sir. As of now, it's always a race against time. Do you think this technology we can easily integrate in our setup so that our technicians, in fact, many of our ER people, doctors, technicians also, they call us at the middle of the night and talk about the acute stroke. Will there be now confusion and will there be a problem with that, or life will become more easy?
Sir, we have to start setting up a protocol. That is the one thing, and education about the technique and availability of the software. That is one thing, and definitely training also needs to be done. So once we go through the initial hurdles, and once we set up the protocol, this is what we are going to go ahead and this thing. So some minor modifications like time-saving procedures, like once the patient has come very early, will be little bit lax. But if he exactly arrives at the time window, means will be very fast. Sometimes integrating of the consents of IV and mechanical thrombectomy into one core. So once we set up this ideal platform and for this thing, then once the protocol is set up and the next treatment plan is set up for everybody, so everybody will be on the same platform right from the consent to the financial counseling, then we definitely will have the hiccups in the 1-2 months. So once we are through that, I think we should be able to select much more candidates and increase the volume load.
Yeah. Possibly we need to have some training programs for our hospital, all our other group hospitals, once it is ready.
Yes. Yes.
Yeah. Mm-hmm. Sir, Manas sir, you were talking about the volume of the blood. In any other condition also AI helps apart from the stroke, sir, in neurosurgery department?
Yeah, means in emergency situation, in addition to blood clot where we remove blood clot, it is also used for diagnosing aneurysm which causes blood clot. With rapid CT angio, again, we don't have to wait for a radiologist report. Then with AI, you can get a report. And nowadays, even the tumors also are reported with AI, that what kind of tumor also can be reported with AI in the size of the tumor, and the urgency of surgery can be predicted with a report.
Coming back to call, sir. Now, the thing is that you're talking about first of numbers. But as sir pointed out that many of the large cause strokes, they don't do well. Will AI help in selecting the particular patient? For example, can I make a decision? No, I will not. Even though there is occlusion, I will not go ahead and do the procedure. Or even if the time has cost, but if the patient, yes, he is a good patient, we can go ahead, sir.
Yeah, we can definitely refine the selection. See, as such, we'll get many more patients, but in addition to getting many more patients, we'll also be able to exclude some patients. As we have shown in these slides very nicely, that if the area of damaged brain is equal to the area of dysfunctional brain, that means there is no further brain to be saved, so we should not offer such an expensive thing to him, and particularly when we know that. So it will definitely help us to exclude also patients whom we would have otherwise unnecessarily done mechanical. So it will refine our selection. Yeah.
Any questions from our audience or anything we would like to ask you?
Can I ask something? Actually, I tried to raise my hand. Can I ask?
Please, sir. Please go ahead, sir.
I would like to know if your center is you take decision based on CT or based on MRI?
MR, sir. We are predominant MR center, sir.
Okay, perfect. I mean, we are also completely MR-based center unless patient is not cooperative or he has some contraindication, and this tool absolutely helps. You will love this tool.
Yeah, ours also we have taken the MR package one, sir, the rapid MRI based on MR, sir.
Is this AI is only for brain or maybe myocardium or muscle, bowel?
Sir, in fact, I was thinking of asking the same to you, sir. Sir, AI in heart, how is it helping, sir?
No, but if it is able to do it for Sagar Oak, do you have any idea or any research is going on, any occlusion it can able to identify this AI?
Sir, I am not aware of myocardium, but what I feel is that they keep things very simple. They see an occluded artery, they open it. They don't worry about the myocardium.
No, it is used in liver.
Oh.
Yeah. In CT, coronary angio, it should be able to predict. But the greatest advantage in this is everybody means there is a uniformity in decision making. The patient who comes to the hospital, he did not think that I need only a senior physician to treat. Even anybody is there with 1 year experience will give the same opinion, and somebody has 20 years experience. So that is the advantage of AI, that one need not wait for a 20 years experience to give a same opinion. What do you feel, Dr. Kaul?
Yeah. Yes, sir. The other centers, anybody, any questions, any that can be as silly as possible. We will try to have such brilliant minds. We won't get it at the same place. Oh, there would be definitely, because of the software license what we are supposed to take. But I think so. You must have seen the patients, rather than decompressing, if we remove the clot and they improve fast, then that would be a saver for a lot a day. What do you say, Kaul sir?
No, what was the...
they were talk additional
cost will. I think only Dr. Bhaskar Rao sir can talk about it.
No, actually, it will not cost. It will help. See, one is if the patient develops stroke and hemiplegia and he has to stay 3-4 days and lifelong the expenditure and all. Now with this AI, and if he can able to thrombolize and he can walk home with next 24 hours or 48 hours. So definitely cost will be more beneficial with this, and also the quality of life. These are the two important things. That's why this is able to help the patient.
Yeah. Please.
Thrombolysis, you are telling 9 hours and 24 hours also. Is thrombolysis available till 24 hours, or thrombolysis till 9 hours and thrombectomy till 24?
Yeah, thrombolysis traditionally is given only up to 4.5 hours. But with this technology, it can be done up to 9 hours. Thrombolysis means giving intravenous. Mechanical thrombectomy can be extended up to 24 hours as per the guidelines. But as Dr. Oak said, that sometimes if you find that there is a lot of salvageable tissue, people have gone even beyond 24 hours. But up to 24 hours is definite.
But thrombolysis is only 9 hours.
Thrombolysis is only up to 4.5, but now we are hoping to make it up to 9 hours. Yeah, only up to 9 hours, because that is where the studies have been done. Yeah.
So just a different perspective, can we use this to look at at-risk parenchyma for delayed cerebral ischemia after subarachnoid hemorrhage?
I'm sure trials are going on that, but not validated as of now. But there is a lot of work on subarachnoid hemorrhage going on at this time. I think by next year, we will have more data.
Yeah, there are some papers on predicting vasospasm, an area of infarct in subarachnoid hemorrhage. But it's not being sold, validated yet. Yeah.
Sir,
Dr. Sita, I'm sure finally Dr. Sita will use it more than anybody else, because she sees maximum number of patients. And okay.
So, talking about the junior senior, sir, the bigger question, as they say, AI is taking away jobs from everybody. Is there a real threat, sir, from the neurology point of view? Because we are the most...
you want to take something?
That I'll ask, sir.
You see, in 1978, 76 CT scan came. And there was a panic among neurologists. I was around at that time also. They said now there is no job for neurologists because CT scan has come. And the number of neurologists at that time was about 30 in India.
Yeah.
Now there are thousands of CT scans in our country and the number of neurologists is 3,000. So the neurologists have only increased. Please remember one thing. After all this is only artificial intelligence. So to use that artificial intelligence, you need the other intelligence also.
Sir, from neurosurgery, I never thought that robot will perform a surgery. Now we have a Da Vinci in our hospital. Do you fathom that at any time this AI will or robots will take over surgery from us?
Yeah, the robot doesn't operate unless we are behind them. So the AI will not work unless the radiologist or physician are behind that, because they are not medical legally liable in court of law. Is the person who is signing below that their court of law in the court of law. It will not reduce the work; it will increase the work. Like if you look at the history of private hospitals, it started with only cardiologists, with a cath lab and 15 cardiologists, because round-the-clock service. And now hospital has to think that they have round-the-clock service of neurologists and intervention. So the 24/7, it's dedicated cath lab is available, dedicated MRI. Then because the number of patients will increase tenfold in few years once people are aware that brain is as important as heart. All these years we gave only importance to heart, and brain has been neglected.
See, basically when the computer comes, everybody thinks most of the people will become unemployed. Yes. After the computers, the employment has increased. And especially the robotic surgeries is a robot-assisted surgery. It is not a robotic surgery. So most of the people think that a robot performs everything. It is a robo-assisted surgery. And
Anantaram sir, I think so. Will it come that there's so many deep learning AI papers? We say that CT, ultrasound reports, everything will be done by artificially. Is there a real threat?
The volume load that amount of time we take to report a scan will definitely increase, because once we expect that in the report all these findings needs to be added up and everything needs to be concised, and then you have to give an impression. Then the amount of work somebody has to dedicate for a scan will definitely increase. And second important point is anybody has to sign the report and validate it finally. So they will increase our workload definitely, but definitely losing the job will not happen.
Sita madam, I had a question, madam. No. There are many papers in which they are talking about EEG reporting. EEG can be done just computer based. Your feedback.
But that research is going on for more than a decade. So, but still you need the human beings to certify that is right. So everything reported by the artificial intelligence is never precise, because it reads all the artifacts, so many other things in between. So it needs a lot of refinement.
There seems to be there's a tipping point. After that tipping point, when it's achieved, when it will be achieved, we don't know. There's a hypothetical tipping point. After that, machines will possibly become more clever than us. That will be receive that tipping point that I don't know. Raghavendra has a question. Doctor.
Two things for me. What is the sensitivity that we get the report that are we over treating by thrombolysis, or is it so sensitive that we can follow it?
Sir, talking about the sensitivity of 4.5 to 9 by using the AI.
No, I think it has just started. What you're asking is that what is the sensitive specificity? That will depend after we have done those numbers, and then we will.
Yes. Sir, Oak, sir. Sir, specificity and the sensitivity of rapid AI for thrombectomies. How do you see that by naked eyeballing versus using the AI?
So a couple of things. One thing I would like to point out that with rapid AI, now ours, as we discussed, that my center is an MR-based center and we have a radiology backup 24/7 as well. But there are many centers where there is no radiology backup, and then these AI tools will really help because we actually know what is the penumbra and what is the core, and we really don't need a radiologist help in the middle of the night. So that is an advantage. So radiologists need to worry, not the neurologist, number one. Number two, yes, obviously sometimes you may feel that clinically this patient is stable and we see some penumbra, but the sensitivity is close to 95 to 96% when in choosing the patient. And sometimes the
the connection is unstable.
But it does help between. Am I audible?
Sir, there is a little connection failure, sir. Any point you would like to make, sir?
Just one. Yes, so we were previously using ASL, which doesn't first distinguish between chronic ischemia and acute ischemia, but with rapid software, we exactly know whether this patient has acute ischemic stroke or this patient has a ongoing chronic occlusion for a longer time with collateral circulation. So that also rapid helps us selecting. So it's a good tool that way.
Yeah. Thank you, sir.
Sir, one question to Anand, sir. Anand, sir, how are you going to link this, sir, here from Srinivas? So how are you going to link this AI to other network hospitals of KIMS? Because that's going to be in the main branch. So how should we coordinate in the late night with this AI? What would be your plan?
Sir, whatever it is there, if the same app which is downloaded by in the same app, it will be like you are selecting, like in the medicine apps, you are selecting which center you are trying to see. So same center you try to pick it up, and then the same center results will be seen, and the same center.
But our MRI is not linked to this AI tool, which will be in main branch.
Currently, wherever the MR is performed, no, sir. If you are performing, like Kondapur is planning to do the MRI diffusion and perfusion in their setup, so the data will be analyzed there and it will be sent back to that center only. So that you will be taking a decision based on that.
Miss, that's what Dr. Bhaskar Rao was telling, that all centers, the 12 centers, MRI will be connected so that any MRI is done anywhere that can have an automatic report that what is the mismatch and whether this is good for starting thrombolysis or not. So it's good for neurosurgeons because we also can start thrombolysis, and any physician can start. And the patient needs, I just asked Dr. Kaul, like if the patient needs thrombectomy, then can they be shifted on the way thrombolysis is given and then shifted here for thrombectomy, because every center may not have facility for thrombectomy. Can you just explain?
Yeah, this artificial intelligence can be done on the hospitals which are connected to this hospital by network. The network people will do all that. Hospital network will assure that. Or this is called spoke and hub model of stroke, in which this will be the hub and there will be many spokes that can be 5 hospitals, 10 hospitals, or maybe right now we are thinking only of KIMS hospitals, but eventually other hospitals also may be connected. So many times patients are brought from various hospitals, and here we do many studies and finally find that he is not eligible for thrombectomy at all. So which puts a lot of drain on the resources of the patients, the hospital, this hospital also. So by this technology, what can be done is that patient can be given initial intravenous thrombolysis in his hospital. And then with this technology, we can know, is he an eligible patient for mechanical thrombectomy or not. So from here only, we'll know even before the patient has come here, so that a lot of time will be saved. By the time he comes, we are all ready to take him up for the mechanical thrombectomy, provided those hospitals are connected in our network. So that way it will be very effective, cost effective also, time effective also.
See, most of our groups, and then we are trying to, wherever there is a diffusion is there, I believe we can able to do this artificial intelligence. The second important thing as far as the thrombectomy is concerned, we are trying to develop the interventional radiologist who can able to travel in less than 2 hours distance, even in Andhra and in Telangana and Sarkar, Rayalaseema, so that will be definitely useful for all our KIMS patients, whoever comes to the KIMS group, whether it is a Nellore or Kurnool or anyone. All these services are being done. There is no need to come all the way to thrombectomy here or maybe to go from here. Over a period of time, I think we'll have all sufficient, these important aspects. Our aim is to provide a good quality care to all the patients so that everybody who comes to the KIMS group of hospitals will definitely have this quality life.
Yeah, the end point is that only to provide the best possible service, especially stroke patient, because as we know, stroke can be devastating, and the AI possibly will go a long way in providing early service and precision service to our stroke patient so that they can recover faster. Thank you, sir. Thank you all for being with us today, this afternoon. Thank you, Oak, sir. Thank you, sir.
Thank you so much. Thanks for making me a part of this wonderful session. Thank you so much.
Thank you,
Thank
sir.
you very
And
much.
best of luck.
Thank you.
Recording stopped.
So we don't require senior most.